Now that we were able to hear about Josie's story, we're going to take a look at human factors. Human factors is the study of all the factors that make it easier for humans to work the right way. We know that we can't change the human condition, but we can change the condition under which people work. Think about Josie. We can take a look and say if there were different processes or hard stops in place, would that same outcome have happened? Would good communication between teams have prevented Josie from passing away? It's really important that we take a look at the work and processes and figure out how do they need to be designed. That way they're compatible with physical and cognitive abilities and all the limitations that come with human users. There are error reduction strategies that can help us. This includes avoiding reliance on memory simplifying processes, standardizing using constraints, or forcing functions. That can be similar to the EHR where you're forced to acknowledge, or if there's an interaction with the medication, something will pop up and alert you to that interaction. We also use things like protocols and checklists. That's why we have policies in place, because they help standardize and inform us of what that process should be. It's similar to that of the 2 sign-off system for insulin. We can't give insulin without having 2 nurses sign off on that. That's a double check. That protocol and checklist. That makes sure that we are giving the right medication to ensure that it's quality and safe care that we're providing. We also like to improve information access. Many of you have probably heard of the Health Information Exchange to make sure that we have all the right information at the right time. We try to reduce those handoffs again to prevent error. Sometimes when we communicate, especially if we have a lot of patients that we're caring for, we forget things, and so by reducing handoffs, that allows us to reduce the likelihood of that communication error. We also try to increase feedback. This is where patients' families' feedback is important. Decrease look-alike, sound-alike medication. We try to automate things as much as possible, but in a careful way. For instance, that pain medication that Josie was getting was with a button. She had to press the button with pain medication. But we have to be careful with that to make sure that we have the right systems in place to prevent safety issues from occurring, and then taking advantage of habits and patterns. This is one that is not often used but really should be. If our frontline staff workers have a habit or a pattern that's safe and effective, we want to take advantage of that, so it's easier to follow and less likely to drift. All of these strategies are the interventions that we use for performance improvement. It's how we measure the quality of care that we're providing. Let's take a look at measurements. This is how we know if the care that we are providing is safe and of high quality. It's critical to testing and implementing change, and it shows whether any changes that we've made are leading to improvement. Oftentimes, they don't need to be complex. There's 2 types of data: quantitative, which are those numbers, the outcome measures, and qualitative. That's the feedback we get from patient and families. The care we received here was great. The communication between the staff was wonderful, or I felt like it was not easy at nighttime when I was trying to rest during my sleep time. Structure measures are one of the measures that we look at. This includes characteristics of the environment, staffing levels, equipment, organizational structure. Do we have enough staff to cover the patients? Are staff overloaded where they're becoming too busy and they're not able to get information quickly and efficiently? There's also characteristics of care providers. How much education, training, or certification that they receive, and with structure measures. It's known that good structure doesn't always guarantee high quality, but the good quality that we provide is unlikely. If that structure isn't in place, if we don't have appropriate staffing levels, if we don't have the appropriate training or education needed, this is why licensing and accrediting bodies often focus on the measures of structure. Here's some examples of what those structure measures could look like. The percentage of board-certified physicians, the staff satisfaction scores, staffing ratios, and then other things like electronic medical record, adequate sprinkler systems, and fire doors. We also take a look at process measures. We'd like to take a look to see what is in place during the delivery of care. Was it the right action taken? Was the action performed well? This is where human factors come into play. If the right things are done, and done right, good outcomes are more likely. Here's some examples of process measures. The frequency of compliance of hand hygiene, the number of surgical patients where they were given the prophylactic antibiotic, just to name a few. Finally, we have outcome measures, and these outcome measures measure if the care was achieved. If we have that consistent practice of effective processes, which are those process measures we were looking at to increase the likelihood of good outcomes. We know that good outcome measures mean higher quality care, which is why we focus on it so much. Some examples: the percentage of surgical patients with post-op infections. We thought that process measure of whether that prophylactic antibiotic was given. We also take a look at mortality rate for patients, like the day for specific diagnosis, and we also like to take a look at readmissions or acute care utilization. And here's our second polling question for today. Which of the following best describes a process measure as explained in the presentation? A. Characteristics of the environment or care providers, for example, staffing levels, board certifications, sprinkler systems. B. What takes place during delivery of care? Was the right action taken? Was the action performed well? C. The end results of care, for example, post-op infection rates, mortality, readmission rates, length of stay. Or D. Staff satisfaction scores or percentage of board-certified physicians. The correct answer is B. What takes place during delivery of care? Was the right action taken? Was the action performed well? In closing, quality in care is really important. It always has been important, and we all play a role with improving and maintaining the quality of life with others. We know that if we aren't meeting those metrics that we set out, if we're not meeting our outcome measures, if we're not meeting our structure measures, it can mean poor quality. We want to make sure that we all play a role in helping achieve that. Thank you, and I hope you have a great day.